Welcome to today's webinar. I just want to go over a few of the technical aspects before I hand it over to our host for today. So for everyone who's attending, there are two different chat boxes in the Zoom webinar platform that we are on. The first one is just a regular chat box. That's where you can put any comments, or if you have any technical issues that are happening, if you can't hear someone or anything like that, you can comment it there. But if you have any questions, there is a Q&A option in the bar, and that's where you can add your questions. I will monitor that and make sure that we mark it for the question and answer section at the end. In addition, you can also save your questions and ask them when we do get to the questions and discussion section. But otherwise, I will just hand it over to Bev to get started.
Thanks, Annette, and it's great to have all of you on the call today to have an opportunity to talk about this interesting project, Sick, Scared, and Separated from Loved Ones, the work in 2019. We'll be reporting on the Better Together learning community for hospitals in New York. We are very pleased to serve as subcontractors to the New York Public Interest Research Group and to have the wonderful support from the New York State Health Foundation for this important work. Next slide, please. I'm Bev Johnson. I'm President and CEO of the Institute for Patient and Family-Centered Care, and I'm joined today by Deborah Dokken, who serves as the IPFCC coordinator for patient and family partnerships. Deborah brings her insights and perspectives and experience of being a family member in a number of healthcare settings and has served as a leader for many of our partnership projects, particularly the Better Together campaign. Next slide, please. And our partners in New York, Blair Horner is the executive director for the New York Public Interest Research Group, and we have worked with Blair over a number of years, and we're very grateful for his thoughtful advocacy in the state. And Megan Ahern is the program director at NYPIRG, and she has really been the researcher extraordinaire on this project from the beginning. So they will be presenting on parts of this work as we move along in the webinar.
Next slide.
And today we're going to talk a little bit about the Better Together campaign, how and why it originated, and the progress over the last 5 years. We'll then have Blair and Megan talking very specifically about the findings and recommendations, because this is a journey for healthcare organizations to change the concept of families as visitors, and it's a profound change in organizational culture. So you'll hear some discussions on where New York State is, and I think we'll be able to draw implications for wherever you are in North America. And we'll summarize the overall trends in policy and practice related to family presence, and we hope to leave lots of time for you to share comments and raise questions, and we look forward to that dialogue. Next slide, please. And so it's a pleasure to turn this over to Deborah Dokken, who's been the lead for the Better Together Partnering with Families campaign.
Thanks, Bev. We thought that very quickly, before we hear about this important report from Blair and Megan, we wanted just to give you some quick background about IPFCC's Better Together program, since in one way it guided a lot of the activities leading up to the report and its findings. So Better Together is a national and an international program whose goal is to change the concept of families as visitors to families as care partners. And that would also mean that as care partners, family presence and participation would be welcomed and supported 24/7. And it would also mean acknowledgement of the positive impact of family presence and participation on the quality of care, the experience and safety of care, and even the outcomes. And although we will not have time today to share a lot of data about those things, we will share one slide in a minute. Next slide, please. As we talk a little bit about Better Together, we wanted to give you two perspectives from the healthcare field and support for family presence and participation. This first quote is from an intensivist named Samuel Brown, who is in Utah and who started something called the Center for Humanizing Critical Care. And quite frankly, in this quote, Sam Brown doesn't mince words. He really refers to visiting policies as physical barriers to what we're all advocating for now, which is patient and family-centered care and patient and family engagement. And goes on further to say that visiting hours have nothing to do with patient and family-centered care, but in fact, they are clinician-centered. Next slide, please. This slide is from the person who was in 2014 the president of the American Society of Healthcare Risk Management, an organization that was one of our partners in the Better Together program. And we wanted to share this slide because Sam Brown is a clinician. This slide is about a group of people involved in healthcare who are risk managers. And so from a different perspective, they too are advocating that families are not visitors, that they should be members of the care team because it is a proactive approach to risk management, which in this day and age is a pretty strong statement. Next slide, please. So just quickly, kind of the history of the Better Together program. It was launched in June of 2014 in the US with an extensive toolkit of resources for hospitals, everything from profiles of hospitals who've already done this work, to sample policies, to website templates. The program also extended and was adapted across Canada through another of our partners, the Canadian Foundation for Healthcare Improvement. And I'll talk a bit more about Canada in a minute. But then with the generous support of two funders and through our collaboration with the New York Public Interest Research Group, we were able to focus Better Together in New York State. First in New York City, that initiative was completed in June of 2017. And I do want to mention there that the public hospitals in New York City were very, very involved in that initiative. And our most recent initiative related to Better Together and New York is the Learning Community for Hospitals in New York State, which was completed like now.
This week.
And as a result of those two New York initiatives, there have been special editions of the publication Sick, Scared, and Separated from Loved Ones. And you'll hear a little bit more about that later. Next slide, please. Although we don't have time to talk a lot about data in support of family presence and participation, we wanted to share this slide and this data that came from a study of patient and family engagement practices. The study looked at almost 1,500 hospitals and found that hospitals that allowed unrestricted access to patients by family members and care partners had HCAHPS scores that were 3 points higher. Now, there's other data, but we think this one is particularly persuasive in the current environment. And we can help point you to other data if that's something you are interested in. Next slide, please. And we did want to just talk a little bit more about our Canadian colleagues who embraced Better Together, and as you see on this slide, talk about loved ones as partners in care. Next slide, please. So as a result of Better Together in Canada, 53 Canadian organizations have taken the Better Together pledge, which means that they have agreed at the leadership level to either review their current policies together with patients and families and clinicians, to develop a new family presence policy, or to implement a new policy. And those different levels, of course, depend on where the organization is starting. CFHI is also continuing its Better Together work. Right now, they are beginning to do further assessment of what has already happened in their campaign in Canada. And they are about to begin something that they're going to call Better Together 2.0. And that is to expand their efforts and what hospitals are doing from changing visiting policies to looking at things like bedside rounding and bedside change of shift report. So I'm going to turn it over to Bev now, who's going to...
So the parallel to the Better Together campaign, a really important act was passed in the United States with a lot of support from AARP and the United Hospital Fund in New York. The Caregiver Advise, Record, Enable Act, or known as the CARE Act, I think is very important and relevant to the work of the Better Together campaign. It's acknowledging that we really put patients at risk when we isolate them from people that know them best, and that the care partner, it could be a family member or other person designated by the patient, is really important to help the patient to assure safety and quality while in the hospital, but very importantly, in the transition to home, and that they have an opportunity to learn about what's expected of them when the patient comes home, and that they can have a chance to become more confident in it. So with this, again, it is positive reinforcement that we need to change the concept that, quote, families are visitors. The hospitals are encouraged to record the name of this care partner, and it could be a family member or somebody else that would be in the medical record, that they're notified ahead of time about the transition to home, and then that they are provided with education and instruction. And so all of us who do this work believe that this is not something that happens in the last hour before a patient is discharged, but they're integrated in the care process. Next slide, please. We do have work to do. Only 39 of the states have passed this bill, so we do have work to go, but one of the original ones was New York. So in the Better Together learning community in New York, we were really pleased to partner with the New York Public Interest Research Group and New Yorkers for Patient and Family Empowerment. They've been working together for since 2010 on this culture change in healthcare organizations. Next slide, please. So the focus of the learning community, we had two cohorts of acute care hospitals, one large cohort from a large health system, Northwell, and then 5 or 6 health systems in the other cohort. We conducted a series of coaching calls over about a 16 month period with these teams from hospitals, and they participated in a Better Together organizational assessment tool at the beginning of the project and then at the end of the project. And I urge you to think about that organizational assessment tool. Might be very useful to each of you and your organizations as you move along this journey. And then the conclusion of the learning community was the publication just last week of the 2019 edition of Sick, Scared, and Separated from Loved Ones. Next slide, please. So I'm pleased now to turn it over to Blair Horner, who will describe this wonderful organization and the advocacy work that it does. Blair?
Thank you, Bev. Can you guys hear me okay?
Perfect.
All right. Thank you, everyone, for attending this webinar. Just briefly, the organization New York Public Interest Research Group has been around now for about 45 years in New York. We're a nonpartisan, not-for-profit, and we work on a wide range of issues: environmental and energy issues, mass transit issues, government reform, higher education, consumer protection, and related to that is in the issues of healthcare. And we've been particularly interested in access to healthcare in New York, and as well quality of care in New York State. And that sort of that work has led us to examining this issue. And I just mentioned quickly that we also thank the New York Health Foundation and United Hospital Fund for helping us to do this work. We started, as Bev mentioned, working on this issue back in 2010, and have issued 4 reports. The first 2 in 2012 and 2013 really looked at the hospital visitation policies of all the hospitals, large hospitals in New York. And then we teamed up with Bev and Deborah and Better Together for the last 2. So let me just move to the next slide, please. So as Deborah mentioned earlier, we worked with them on the first report that came out in January 2018, and focused really on the practices in New York City hospitals, including H+H, but also other hospitals in New York City. We had the same sort of format in terms of how we examined the issue. Meg will go over that in some detail in a minute, but looking at sort of reviewing policies, then looked at how we could coach them with Deborah and Bev in trying to get them to change practices, and then reviewing what happened at the outset. So the first report looked specifically at New York City. Please go to the next slide. And then the most recent one that came out this month that looked at the hospitals. We looked really at the earlier reports that we did in 2012 and 2013 to identify hospitals that had the most potential to grow in terms of this work. We looked at sort of a regionally diverse system of hospitals and any that had large networks. And the results are, let me turn it over now to Meg. Meg, you want to take it over from here?
Sure. And just wanted to thank Deborah and Bev and the whole IPFCC team for their work with us in this project and for putting together this webinar. As Blair was mentioning, we set out at the beginning of the project by surveying 40 hospitals across the state, from North Country and Buffalo down through the state, through the city, and out to Long Island, on the hospital's visitor policies and their website communications. We surveyed the first time in 2018 in September and October. And then IPFCC took over to reach out to hospitals and hospital networks to invite them to participate in the Better Together learning community, which was hosted in 2 cohorts of coaching learning communities. And then after that period of had ended of the learning communities, through a series of calls and follow-ups, NYPIRG resurveyed the same 40 hospitals in July and August of this year, and then analyzed the results and compared the two surveys into the report, Sick, Scared, and Separated from Loved Ones, 4th edition, which we just released. The full surveys, both on policy and on website communications, are available in the appendix of our report, Appendix A and B. And folks can download a copy on our website, www.nypirg.org/SSS2019. Or you can just search for the name of the report on our search bar, and it pulls up all the reports we've done on this since 2012. But just to summarize a few of the questions that we focused on for policies on family, caregiver, care partner presence, and visiting, we both looked at general medical surgical units visitor policies and also ICU and CCU policies. The first 2 questions focused on visiting hours during morning time, before 12 p.m. And whether the next question was whether there was the policy disclosed that the hospital may provide flexibility for support persons or family caregivers, care partners, and whether the hospital allowed for or accommodated 24-hour presence of a patient's designated family caregiver, care partner. Switching over to the ICU, and that was for general medical surgical units. Switching over to the ICU, we focused on extended periods of visiting hours. So whether there was periods longer than 2 hours, longer than 6 hours, longer, or excuse me, 2 hours or longer, 6 hours or longer, 10 hours or longer, and whether they accommodated a family caregiver or care partner for 24 hours. Then a bonus question, we love bonuses, was whether or not the policy allowed for children as visitors, importantly without prior notice, but the requirement of having supervision by an adult did not discount any points in that bonus question. For the website communications survey, which was a separate 10-point scoring with an additional 1-point bonus, which is the same as the scoring for the hospital policies. We asked about whether or not the visitor policy was posted on its website, on the hospital's website. Secondly, if a person could find that policy easily. So if there wasn't 5 clicks or you know, a maze of redirections that a potential visitor or family caregiver or care partner would have to follow to find the policy. If it clearly communicated that the patient had a right to choose who could be present at the bedside, whether the website posted policy treated a family caregiver or care partner, encourages patients to designate family caregiver or care partner, which goes beyond just having a right to that, whether the website posted policy considered family caregivers and care partners to be part of the healthcare team rather than simply visitors. And then the last 3 questions and the bonus question identified helpful communications for prospective visitors and family caregiver care partners. For instance, instructions that anyone visiting that's coming to the hospital as a care partner or a well-wishing visitor should sanitize and wash their hands before entering a room, that notifying the public that one should not come to the hospital if they are ill or have a cold or a cough or even a non-serious or seemingly non-serious illness that can be a real risk for someone in the hospital. Whether there's information about gift items that should be avoided and food that should be avoided that can trigger allergies or be go against the patient's plans, like nutrition plans set out by the hospital and the caregivers. So that's a brief summary of the questions that were reviewed. For the hospital policies, we mostly looked at websites, and then if we had follow-up questions, we made a round of calls to the hospitals to clarify. For website communications, we didn't do any follow-up calls. It was just what the website posted policy was, as websites are a hospital's, you know, most public-facing document and where prospective visitors and family caregiver care partners look to these days to get the information they need or look for the information that they need. All right, next slide, please. So here's what we found. There's both good news across the board and both items that can be worked on. So what we found is that some hospitals in New York State provide more hours of visiting than others and better accommodate the presence of family caregivers and care partners. That hospitals who participated in the Better Together learning community improved their scores during the survey period more than hospitals who did not participate in the learning community. Just to go into a little bit more detail on that, during the survey period, 16 of the 40 hospitals' policy scores improved. So simply on policy, not on website. Those who did not participate in the IPFCC Better Together program saw an average increase of 2 points. And again, that's out of a 10-point system with a 1-point bonus option. So that was an increase of 18%. The hospitals that participated in the learning community saw an average increase of 4 points, so pretty much doubling the increase, 36% score increase. And the top 3 hospitals that's increased their scores the most were hospitals that participated in the IPFCC program. Next slide, please. So first, the good news on policies: over half received a high score of 8 or better. 17 of those hospitals received a perfect 10 score, and some additionally received a bonus point for policy on children as visitors. So that's really great to see. 17 that, you know, were so high scoring that they, you know, wiped the board clean and scored really well. and 2/3 of the hospitals were found to provide 12 or more hours of visiting time per day, with 17, again, offering 24-hour open visitation for their general medical surgical units. 2 additional ones get half credit for strongly implying that they would offer 24-hour flexibility. But more work needs to be done. As you can see in the slide, 22% offer no morning visiting or only 1 hour of morning visiting hours, which we find to be an important part of the day for family caregiver or care partners to be allowed bedside presence as shifts change and information is communicated during new rounds. It's really important for a family caregiver to be present to allow for seamless transition of information and any healthcare information that might be important to communicate to a new nurse or doctor on shift. 52% of hospitals had policies which ended between 8 and 9%, or excuse me, 8 and 9 p.m. And 25% of hospitals had policies that forbid or discourage children from visiting. And I just want to dive in a little bit deeper on children as visitors. So 23 hospitals' websites, or 58%, explicitly communicated that children could visit. And that's an improvement from what we saw in 2018's report. But a quarter of a hospital's websites, or 10, explicitly forbid or strongly discouraged or required prior authorization for children visitors. And, you know, we wonder about what differing grounds hospital staff may give or not give for prior authorization, and wonder if it might be inconsistently, decisions may be inconsistently made. We did find that there was a few great examples of child visitor policies, and just to share a few of them, I have a good, better, best list. In the Rochester Regional Health System, specifically the Newark Wayne Community Hospital, had a good policy that said children under the age of 14 must be supervised by an adult at all times. This explicitly provides information about child visitors and does not discourage or disallow child visitation. Even better than that, Northwell Health, pretty much the entire system that we looked at, had a policy language that said children are welcome to visit a family member, but those under the age of 16 should be supervised by a responsible adult during the visit. So that includes really encouraging information that explicitly says that children are welcome. And then one of the best policies that we found was Westchester Medical Center, whose policy said children are welcome visitors, but must be accompanied by an adult at all times and never left unattended. So that, again, underscores that children are welcome. There were 6 hospitals that did not provide any guidance on visitors who are children. That did not end up scoring a bonus point for those hospitals because there still may be questions about what the policy is. Next slide, please. So 20% of hospitals that we surveyed had no flexibility in hours of bedside presence for designated family. And 35% had provided no accommodation for 24-hour presence of designated family caregivers or care partners. These are numbers that we'd like to really see go down in future iterations of this survey. Next slide, please. So transitioning to website communications. while we found that some websites communicated really well for providing information to prospective visitors and patients and family caregiver care partners, there was still work to be done, and no hospital scored a perfect 10 on their website communications, or you know, additionally scored on the bonus points. As I mentioned earlier, 17 of hospitals received a perfect 10 score on policy. None did on website communications. However, on a positive note, again, the hospitals who participated in the Better Together learning community improved their scores higher than hospitals who had not participated. And specifically, hospitals who did not improve their score, or I'm sorry, hospitals who do not participate in the learning community but improve their scores, increase their scores by an average of 1.2 points, or an 11% score increase. Hospitals that had participated in the Better Together learning community increased their website scores by nearly 3 points, a 25% score increase. And again, the top 5 largest increases in scores on their website communications belong to hospitals that participated in the learning community. So that was really, really encouraging to see. Next slide, please. Focusing in on a few specific questions. Does the website posted policy encourage designation of a family caregiver or care partner? It was about split down the middle. 45% did, a little under 50% did not, and there were 7.5 who scored somewhere in the middle. They strongly implied that or had weaker than encouraging language, but not nothing. So that those sort of ambiguous 7.5, we'd love to see provide a little bit more clarity and join the 45% who explicitly do encourage the designation. Next slide. And does the website posted policy refer to designated family caregivers and care partners as part of the healthcare team versus well-wishing visitors? 35% did, 40% did not, and 25%, a pretty hefty amount, was ambiguous. I want to highlight a best practice from Northwell Health Systems. Their entire Your Care Partners section of their website sites pretty much across the hospitals that are part of the health system had really A+ language around designating a healthcare partner and considering them part of the healthcare team. So just to read how they write it, and also to note that this language came from the IPFCC Better Together template website, which I believe IPFCC will share at the end of this presentation. So to start, you, your family, and your care partners are all essential members of your care team. By working together and listening to your goals, concerns, and needs, we build understanding among all members of the team and develop the best plan of care with you. During your stay, we encourage your participation. Be sure to ask questions, voice your concerns, and utilize our helpful resources. So this lays out very clearly that both the patient, their family, and their care partners are part of the care team. It gives specific instructions about how to participate and that their participation is valued. All right, next slide. So to wrap up with some recommendations that the report finds, we, of course, based a lot of our recommendations on best practices that the Better Together community project recommends. So if Deborah or Bev have any color to add to these recommendations, I would certainly welcome that. But firstly, recommendation number 1 is to clearly state support for family caregiver care partner presence and 24-hour presence. Recommendation 2, that provide substantial visiting time in the morning for reasons I previously went over. Recommendation number 3, encourage patients to designate family caregivers or care partners and explain what that role entails. 4 is to clarify that the family caregiver care partners are part of the care team and not merely well-wishing visitors. And next slide, please.
And just before you leave that slide, Megan, I think all of those hang together as just being very clear and consistent with the CARE Act, that people are proactively saying families and care partners are important to their loved ones' safety, quality of care, the transition to home and community. We have to shift the public perception that they are restricted visiting and have no role. So all of these hang together as looking at changing how you write the policy and how you communicate that policy through websites and direct care practices.
Great, thanks, Bev. Number 5, that hospital policies should accommodate children as visitors, and hospital policies can address unwanted behavior, but not unwanted people. And to add on to that, having explicit policies that address children gives people more of a specific instructions, more details about who is welcome when, and doesn't leave it up in the air. Recommendation 6 is to prominently post safety information, both about coming to the hospital or not actually coming to the hospital with an illness, the importance of hand washing, not just for your doctors or nurses and yourself, but for people visiting as well, and provides information about potential allergies, gifts that should be avoided, and food that may or may not be part of the patient's care plan. Recommendation 7 is to align audit policies that are both written into the policy and what is actually practiced, and to make sure that they're aligned and communicated consistently and transparently. We want to make sure that any policy that's routinely ignored or countermanded ends up really undercutting the policy at all. So making sure that policy and practice align. Next slide. The process should involve diverse stakeholders, including administrators, frontline staff, patients and families, and healthcare advocates in developing or revising policies and website communications. There are formal structures that some hospitals use called patient and family advisory councils, and research has shown that these councils can be very effective in influencing strategies, leadership decisions, and operations to listen to and to include the preferences of patients and their families. Number 9, in developing websites, key hospital leaders who are knowledgeable about the quality, safety, and experience of care, along with patients and family advisors, should work with communications and marketing teams or departments to revise messaging and navigability of websites. This makes sure that all of the communications and policies are in line, and also doesn't set an unfair burden on communications and marketing teams who have one set of skills and might be more removed from a patient and family advisory council or other patient and family centered care teams that are working within the hospital. And last but not least, that in developing or revising policies and website communications, hospitals should be aware of and utilize the expertise and resources in their field, and attend webinars like this to learn more and learn from their colleagues and what's worked at other hospitals, sharing best practices with one another. And I just lastly, to conclude, wanted to share that we did a brief analysis of looking at the trends from 2018 to 2019 reports for sick, scared, and separated from loved ones, and showed an overall improvement that more hospitals as a percentage scored better on policy and on website communications in 2019 than in the 2018 report. Fewer forbid children, more expressly welcomed children, fewer scored in the lower brackets. So we are seeing really a trend towards more inclusive and empowering family and patient-centered care, and that's what we want to see continue to happen. Thank you.
Thank you, Megan, for your thoughtful review of the process of change in New York State. We really have enjoyed working with you on that. I wanted to just highlight briefly, since we had so many hospitals from the large Northwell Health system, it is really an illustration of the importance of leadership and the connection with various key departments and committees within an organization. We're really, with Better Together, partnering with families, changing the culture of organizations and not just changing policy and practice. So here on the circles, you can see where IPFCC and the Office of Patient Experience at Northwell Health work together, and then they have a system of patient partnership councils. They also have what they call culture leaders and patient family leads that they get together on a regular basis. Then they worked very closely and involved marketing and communications all around the work of the website. Facility operations are key to changing signage and to helping the people that work in that department understand what the goal is and to be supportive in an ongoing way. And then the policy and competency committees that were key to driving change across a large system. And then looking at, for practice, you want to look at human resources in that department to look at how position descriptions and performance evaluations are written. So they had 3 shared work groups. They had the leadership support at the system level, and then working with individual hospitals as part of the system, they put together people for 3 shared work teams: policy and staff education, position descriptions, and website and signage. Next slide. So what we learned from this, the learning community, but also from the previous work in New York City, that improvement is facilitated when it's addressed across an entire health system with leadership support. And I want to underscore, with leadership support. This really can be viewed as both a safety strategy, a key strategy to improve scores related to the experience of care. And it does need and require to be really effective leadership support. And when you're in a system of care, to try to get consistency across facilities and departments is important. Next slide, please. So I hope that you have appreciated the shift from presence, from visitation to family presence, and understanding language is important here, that we're talking about participation and not just that we're allowing it or permitting it, but that we're encouraging and supporting it. And Lucian Leape, who I think of as the father of patient safety, said families are respected as part of the care team, never visitors, in every area of the hospital. So we'd like to open it up for questions and comments from anybody on the webinar. And Annette, has anybody chatted in anything that you could read?
We do have one comment. It says, I'm a patient family advisor. I understand the importance of having family near and available. I'm wondering if these policies and practices change in the case of private and semi-private wards. As a patient, I assume my care team have all had records checks, back checks, and signed privacy policy. If I'm in a semi-private ward, I'm concerned about another person in my room.
Well, that's a great question. And I am hoping that we are going to move both in the United States and Canada and other places to all single rooms. It is very bizarre that when people are at their most vulnerable, we put them in a room with a stranger. So from that perspective, we're seeing it change. I think it's very important to help staff have communication with the individuals in a double or even multiple bed room for mutual respect for the needs and considerations of other people. It is possible to have a welcoming family presence and participation even in places that don't have all single rooms. But I think your concerns are well placed. Deborah has a comment.
Well, I always remember in some of the earlier years of Better Together, and we had the privilege of working with one of our Canadian colleagues at Providence Hospital in Vancouver. And they implemented a family presence and participation policy. And one time when we were doing a presentation together, this same question came up. And at that time at Providence Hospital, and the staff member who was presenting with me said, in our hospital, we have 4 bedded wards, and we still make it happen. So we're not suggesting that you don't have to address those issues of having other people in the room, but it doesn't mean that you cannot honor family presence and participation.
There's an academic medical center in the Northeast where the Patient and Family Advisory Council developed guidelines for behavior. I can't remember, they had a lovely way of describing it, so that everybody in a double or multi-bedded room received these guidelines. And it was partly keep your voice down, don't have too many people in the room if your roommate is trying to rest, but they were written from the perspective of patients and families. So that might be something your council would work on. And the other thing, particularly in rural hospitals, when they're multi-bedded rooms, often in those small communities, everybody knows everybody. And I think it's also not a bad idea to have a card about HIPAA and say, you're going to hear things during your hospital stay that we wish we could offer more privacy and protection of your information. And we just ask that you respect other people and the information that you might accidentally overhear. So those are just a couple of thoughts on that good question. Any more questions, Annette?
Yes, so there's one that says, we are interested in evidence regarding family presence in outpatient settings. Examples, pediatric procedural and pre-post first stage recovery areas.
Oh, that's a great question. And I'm trying to think of articles. Let me think about articles. I know that there's very interesting data about family presence accompanying older people in ambulatory care, where it's improved the communication and the follow through of care, and also satisfaction, and that did not take more time. A lot of that work was done by at Hopkins and the University of North Carolina. I have to think a minute. We'll see if we can find anything on the pediatric procedural areas. Nothing's popping into mind right at the moment, but that's a good question. Any more questions, Annette?
Not that I
Or
see
Beth?
yet.
Okay, well, I'll share a couple more things, and because I know we're about to run out of time, can you advance to the next slide? There are further informations about the Better Together Toolkit and how to the template and guidance for exemplary websites, and then you can get access to the 2 reports from the New York Public, or all 4 reports actually, at the New York Public Interest Research Group's website. Next slide, please. I was thinking about the question you raised about family presence in ambulatory pediatric procedural areas. That you might pitch that question at pfcc.connect, and among the 2,000 people that are part of that, you may get some very interesting answers. It's totally free. This is how you can join, and we hope that many of you on the call today will decide to just be part of the conversations, and you might be able to find in the archive material some answers to your question. Next slide, please. And right now we have the call for abstracts out. So we're very interested in what you all are finding across North America. Just as a reminder, we value the partnership with patients and families. So think about how you put together your abstracts. They're due December 4th, so there's plenty of time to submit an abstract. It's an online process. It's not too onerous. And we hope you'll join us in August in the Music City, Nashville, Tennessee. I think it's going to be lots of fun as well as really important work. So I think that's all we have for today. Thank you for joining us. Thank you, Blair and Megan. And we please stay connected with us if we can be of further assistance.
Thank you.
Thank you, everyone.